Hello, everyone. Dr. Yonit Arthur here. You are on the Steady Coach, and it is my great honor today to bring you this interview with Dr. David Schechter. Dr. Schechter is one of the greats in the field of psychophysiologic disorders and has been practicing for almost 30 years. This means that he has seen thousands of patients with chronic, medically unexplained pain, dizziness, digestive issues, and many other symptoms. Dr. Schechter is board certified in family medicine and sports medicine. He is a clinical associate professor at the University of Southern California. He has his own private practice in Culver City, California, and he sits on the board of the Psychophysiologic Disorders Association. He is also the author of a fantastic book that I have often recommended here on my channel called Think Away Your Pain. And we relate directly to the name of this book here in this interview, clarifying that indeed it is for you, even if you have dizziness rather than pain. Dr. Schechter also recently released a brand new workbook with 30 days of journaling prompts that you can buy at some of the links that I will post in the video description or podcast description. So in this interview, we talk about a lot of things. We talk about Dr. Schechter's experiences with patients. We talk about why diagnoses like vestibular migraine are not particularly helpful to patients and what these diagnoses actually are, in our opinion. We talk about neck pain and its connection to dizziness, as well as TMJ or jaw pain and its relationship to dizziness. We talk about how to get better from a mind-body condition, what the diagnosis and treatment regimen looks like for someone who has chronic medically unexplained symptoms. And Dr. Schechter gives you some tips on how to journal as well. So lots of information jam-packed into this hour. I know you'll enjoy it and get a lot out of it. As always, if you enjoyed this video or this podcast, please drop a comment below. If you're on YouTube, please like, share, and subscribe. If you're listening to this as a podcast, please follow the podcast and consider leaving it a review. All of these things help me reach more people. And now, please enjoy my interview with Dr. David Schechter. All right. Hey, Dr. Schechter, thank you so much for coming on today.
Glad to be here.
Such an honor to have you. I know now that we're live, I'm going to pay you all the compliments and just say you're one of the luminaries in our field. You're one of the people who has really worked your entire career to spread awareness of mind-body disorders. And again, it's such an honor to have you on my channel.
Well, that's very kind of you. And I'm looking forward to the discussion.
Yeah, me too. All right. So for those who don't know you, would you mind telling us a little bit about yourself, your background, and the kind of practice you have?
I was a medical student at NYU when I had knee pain, and I met John Sarno when I was experiencing knee pain that didn't improve with the traditional orthopedic and anti-inflammatory medication type approaches. I didn't meet him because he was the guru of mind-body medicine, because he wasn't known for that yet. I just thought I'd be getting some special exercises from a physical medicine rehab doctor. But it turned out that he immediately confronted me with the thought that 95% of chronic pain is psychosomatic, is psychophysiologic, is mind-body. And that threw me for a loop. I felt like a cold blast of Arctic air had hit me. During this warm summer, a lot of people are wanting that cold blast of Arctic air.
Yes.
At that point, it was a surprise. He invited me to a seminar, and when I sat down and listened to him present his ideas, it was transformative in my own thinking. My knee pain gradually started going away. I resumed basketball and running. And over the next couple of years, I had an opportunity to spend a summer with him with a little small research grant to telephone a lot of his former patients, do a little online study on that, and then spend a lot of time seeing patients with him. And that really sparked my career-long interest in mind-body disorders. I came out to the West Coast, trained in family medicine, sports medicine, and eventually established a private practice and reconnected with Dr. Sarno, who I've been in touch with over the years. And by this point, he had published some of his books that were bestsellers, and he was getting calls from all over the country, but had really no doctors to refer them to. So he asked me if he could refer the California patients to me. I said, sure. thinking I might get 1 or 2 calls a year. But once that happened, I was getting maybe 1 or 2 calls a day, or 1 or 2, several calls a week. So I was able to build up my own practice from those referrals initially from Dr. Sarno, and obviously develop my skills in treating these disorders, initially with office visit and a seminar, and then eventually with online materials, a website, the first website in the field, a Mindbody Workbook, and other books that I've written since then.
I love your book.
Thank you.
I love Think Away Your Pain. I just, that's one of my favorites. I just think you have such a great style. So for those of you who have not read it, go read that book. But I'm interrupting you right now because it has pain in the title. And I want to correct a misconception that I think people seeing my channel for the first time might have. Is mind-body syndrome always pain?
Well, that's a good thing. I often tell people who are not experiencing pain, but who have a form of mind-body disorder. Again, there's lots of names for the condition, right? Psychophysiologic,
yes,
disorder, PPD, mind-body syndrome, neuroplastic pain syndrome, neural circuit disease. There's lots of different terms now for, which can be confusing to people as well. But I tell them, if you have a different symptom, just substitute that for pain. So some people have nausea, some people have dizziness. These are not pain symptoms per se. Some people have tinnitus. And so you could say, you can think away any of those. Perhaps I eventually will write additional books or little mini pamphlets to clarify that for people, because they often say to me, well, I didn't see my condition mentioned in Dr. Sarno's books. Yes. Can I use this approach? And of course, Dr. Sarno couldn't mention every condition in his books, even in the one that mentioned perhaps the most conditions, Mind-Body Prescription, which was one of his later books. But yes, you can use my book with dizziness, which is your specific interest, and with other conditions that have been excluded from the biomedical paradigm, for which therefore there is no structural or biochemical explanation, and for which hopefully you've been diagnosed with a TMS or mind-body disorder. Although I know it's tough to get that diagnosis because there aren't enough physicians and psychologists in the country doing the work, although there are many more than there used to be.
Yeah. So you have heard it from the author himself. You have Dr. Schechter's permission to cross out the word pain and just write dizziness instead. And then the rest of the book still applies to you.
Yeah, maybe use a piece of tape. That way you don't
you don't have to deface the book. I like that. So I'm sorry I interrupted you. I thought it was very important to clarify that point very early on. But so you were talking about how you've done all this work in the field. So you've written the book, you have your workbook, you have the website, you have your practice now.
Yeah, my practice for many years, and I counted up at some point over 4,000 patients that I've treated for mind-body disorders in the last 27 years. Maybe it's 28 years now since the practice was opened. And, I just completed a new workbook, the Mindbody Workbook Volume 2, which I co-wrote with a psychologist. So I think it delves a little deeper into the psychology of the condition. But
that's fantastic. Is it out?
Yeah, it's out. It just came out a few months ago.
Well, I know what I'm going to be reading soon.
There's an audible version of Think Away Your Pain, which some people like listening to, especially some of your patients with visual issues might find it easier to listen than to read. And I decided to do an audible version of the second Mindbody Workbook, the updated version. And, it's still something you have to write your answers to or record your answers to. But by listening to the questions, it may be easier for some people. And people love Audible and they have their Audible subscription. So it's easy for them to just get another book without having to even pay additionally for it.
Fantastic. So, and this is available on Amazon or just, okay, I'll link to it.
Amazon's the main source. Yeah.
Yeah, it is at this point. Yes. Okay. Well, I hope we can get a little bit more into the content later on in this discussion, because I know we're going to be talking about what needs to be done for mind-body conditions. So one question that came up when you were talking about your patients. So people with dizziness want to know, of the people that you've seen, is dizziness common? Is it a common disorder? Is it a common mind-body or psychophysiologic disorder?
It's probably less common in my practice than in yours, because that's
yes. I see all dizziness. Yes,
and dizziness tends to be like the second or third thing mentioned to me rather than the first, because I would say the vast majority of people I'm seeing have a pain symptom first. Not everyone, but for example, they might have tension headaches and dizziness, or they might have chest pain, back pain, and dizziness. So dizziness comes into a list for me of symptoms that they'll mention, and I'll say to them, we might be able to help you with that as well, even though many of them had not thought they would get relief from dizziness because they've read books, many of Dr. Sarno's books, my books, other people's books, who really focus more on pain or other symptoms other than dizziness.
Right.
And so when they have it on that list, I say, we're going to work on that. In my practice, it tends not to be the primary, but it's one of the ones that we can help them with. So they're happy to hear that.
Yes. Yes. Okay. And that's true. You have a bit of a selection bias because you're known as a pain specialist. I mean,
yeah.
So people are going to find you if they are suffering from maybe a pain condition. But I imagine you've seen people with vestibular migraine, for example. That would be one that you'd see a lot of.
Right. So that's the term that we hear, right?
Yes.
It's become a popular term. So over the years and decades of my practice, because it's now been decades, there are various medical terms. I would call them medical fads. And I think Dr. Sarno may have addressed this in one of his books, and I've talked about it as well, that a term suddenly begins to spread either in the medical community or the lay community or both, and it becomes a new thing. It's a fad. It's a misconception or an over focus on something. And so vestibular migraine is one of the latest in that long streak or long list of medical fad diagnoses, where neurologists typically, when they can't find the clear cause for this or that, will say, "Oh, it's a vestibular migraine. That's why you're dizzy." But there's not really any clear testing that reveals that, and they don't delve into the same kind of psychological questions that you would do or I would do to really look at the patient in a more global way. And so I've helped many people who've been told that. And again, I know Dr. Sarno was really good at hearing something like that and scoffing at it.
Right.
I'd say respectful, but that's part of how you break somebody out of a pattern of believing something that's not accurate. And I'm not as much of a scoffer as Sarno was. Again, this is he's been deceased now for 7 years, so obviously we're speaking respectfully of him and his after death. This is the 100th year of his birth. I'll mention, just for those who are interested in those kind of things. But anyway, he would scoff pretty powerfully. I tend to be more subtle with it. But vestibular migraine, I mean, it's kind of hanging out there, and they're giving pills and they're giving a lot of the same migraine medicines. And obviously, I'm seeing people who aren't getting better from that, but who then respond to a psychophysiologic approach to their problem. And we'll talk more about that, I'm sure, over the course of this conversation.
Yes. I'm so glad you said that. Someone in the comments one time, I said that it's in vogue, that some of these diagnoses are in vogue, and we are not by any means downplaying the severity and the horrible life altering effects that these symptoms have on someone's life. We're not scoffing at someone's experience,
but not at all.
But we're saying that they're basically trends come and go in terms of the label that they give you when they don't know what to do with you. And
that's very well put. The symptoms are real. We're very sympathetic to the fact that you've had to suffer from those symptoms, whatever they are. It's not your fault that you suffer from these symptoms, but the way out of these symptoms is actually to look inside rather than to look outside. Yeah. Outside meaning pain medication, various types of therapies and injections and other things like that. Inside meaning understanding a condition, psychoeducation, emotional expression, etc. So no, and then your symptoms are real, and we're scoffing at the labeling and how it changes from year to year, decade to decade.
Yeah.
The term fibromyalgia, the people who created that term, it's a term for chronic muscular pain in a variety of areas of the body. But the people who created that term, a number of them have come out and said, we wish we had never created the term because we feel it's done more harm than good. And, I think that's probably true, although we could have a discussion about that. And there are other things where we'll look back and say, that was kind of foolish. Now, remember, physicians used leeches a few hundred years ago, and cupping and bleeding. George Washington, our first president, was killed by a physician who used the techniques of bleeding to try to treat his condition, because that was the medical expertise or fad at the time. So things can be in vogue and still be wrong. That's a key point. And the fact that we continue to get great results with Dr. Sarno's work decade after decade shows us that it's not in vogue or a fad. It's a fundamental principle that we've uncovered that we're using.
You make such good points about the harm, because I arguably now, of course, 50 years ago when something was in vogue, maybe it was spreading through the various groups of physicians who were giving the diagnosis. But now the problem is people are given this obscure diagnosis, and then they go online and they go to Facebook and they find support groups for these various labels, and it becomes this echo chamber of despair and fear mongering. And again, just like many other mind-body syndromes in the past, conventional techniques don't work. This isn't surprising to us that conventional techniques for PPPD, vestibular migraine, MDDS, all the various neural circuit dizziness disorders I talk about, that they don't work because they're not addressing the root cause. But the problem is that people then have their fear reinforced by the label. So there is actual harm being done.
Fear fuels pain. There's no doubt about that. And support, it's good to have support, but support groups often involve, unfortunately, and especially online, people who are not getting better talking to other people who are not getting better. And that doesn't tend to lead to a healing process. So
Yeah.
we in our offices, and I'm sure you do this as well as others, we change the conception of what a patient perceives is wrong with them. And that leads to a virtuous cycle instead of a vicious cycle. If you haven't heard that term virtuous cycle,
Yes.
we can discuss it more, but it's an important concept in healing.
Yeah, go ahead. Why don't you expand on that virtuous cycle versus vicious cycle?
Cycle. Everyone's heard of a vicious cycle. Right? One thing happens and it builds onto another, builds onto another. So, for example, a vicious cycle might be, you're having neck pain and then you get an injection. Unfortunately, the injection makes you worse rather than better. So you have more neck pain. So you go on to another doctor and he says, well, now that the injection didn't help you, maybe you should have surgery. Right. So that could be a vicious cycle of one thing leading to another. There's many other examples in all kinds of fields where that would apply, everything from the stock market to certainly physical and mental health. But a virtuous cycle would be coming into a healer's office and hearing a new diagnosis that has hope involved with it and has a plan involved with it. And then perhaps you apply that plan for a week and you get a little bit better and you get a little more hope and you get a little more belief and you get a little less fear. And so that begins, you can see how that starts to build on itself to a virtuous cycle, which is not to say that everyone who improves from these conditions always improves in a straight line. I try to emphasize to my patients there's often ups and downs along the way to healing, and that's normal. We're human beings and we're trying to change the nervous system. So it's not a straight line recovery process in all cases. There's lots of ups and downs.
Yeah. Yeah. So kind of along along the lines of what you were just saying, then it sounds like that first visit and the way that you're approaching people when they first come in is kind of a key point into this cycle. So I'm wondering if you can tell me more about if someone came to you and said, hey, I've got this mind body thing maybe going on. I have vestibular migraine as a diagnosis. So what does that look like when that person comes to you? What's different about your approach versus if they go to a more standard physician?
Well, I think one thing is that we set aside more time, so it's not a rushed visit. At least 45 minutes for initial consultation, and I work quickly, but I think it's important to have that time. The second thing is that everyone in the office is familiar with mind-body disorders, so everyone's asking you kind of the right questions. So even my assistants will take information down about your symptoms and prior tests, but they'll also take information down if you're a type T personality, a concept that many of you may be familiar with about being very hard on yourself, perfectionist, highly responsible for others, goodist, etc. So we're looking for certain key elements so that when you finally get to meet me, you've already been kind of prepared a little bit with that. And I'm going to ask you to tell me the history of your condition from the beginning. But I'm also going to ask, and then I'm going to listen. I'm not going to interrupt you right away. You get a chance to talk for more than 17 seconds, which is apparently the number of seconds that most people get to talk to in a doctor's office before they're interrupted. So I'll sit and I'll listen, and then I'll ask you, can you think of any emotional events or psychological stresses that were going on around the time that the symptoms began? Because I want to open up the narrative to not just being physical symptoms or a car accident or got hit in the head or something else. I want to look at all of the factors that could be involved, including there was a recent divorce or financial distress, hated my job, hated my boss, other things that might have been going on in your life that are important around the time or just before the onset of the symptoms, and perhaps at other times with flare-ups as well. So we're going to delve a little bit into the dual narrative of the physical symptoms, but also the psychological history. And then I'm going to ask you in more detail about your childhood, learn a little bit about that, which probably no doctor has asked you about before in relation to headache, pain, dizziness, or anything else. And ask you about any other stress-related conditions you've had in the past, because it's not unusual for a patient of mine to come in their 40s with a symptom, be it dizziness or headache or whatever, but in their 20s they had IBS, irritable bowel syndrome. Maybe in their 30s they had TMJ, a jaw pain disorder, and then they come in their early 40s and they have a different thing. So it's not unusual for people to have more than one of these during their lifetime. So I ask about that. Although again, not everyone has had a previous one before the one that I see you for. So we talk about personality, we talk about psychosocial history, talk about stress that you're under right now. What are the three big things that are pressuring you right now? So that's very different. And I want to understand your living situation, all of that. Obviously, I also want to know what tests you've had done. I think that due diligence is very important when you see a Mindbody or TMS-oriented physician or audiologist or anyone else. Make sure that the proper testing has been done, both to exclude the rare, very serious condition, and also to provide reassurance to you and to the physician. A lot of times I'll review imaging myself, especially in areas where I have a lot of expertise, like the back and the neck, MRIs, etc. But I'll look at imaging and other test results because I want to read them myself. And then I examine you. So there's an examination involved. And the examination looks at the area of your body that's affected. But I also look for the tender points that Sarno first identified. There were 6 key tender points that he found that many TMS patients have at least 2 or 3 of those 6. It's not an absolute requirement that you have those spots. They're described in my book in detail with diagrams.
And they indicate what? Having those tender spots, what does that indicate to you?
That you're at higher risk for developing a mind-body disorder. I think we don't totally understand why these tender points are present, but I would say it's a way of determining that the body is holding a lot of tension.
Yes.
In different muscle groups, even in muscle groups that aren't hurting. So somebody might have the 2 gluteal spots but have no low back pain, or they might have the mid back, lower back ones that are on the side of the spine and not have pain specifically in that area, or not realize that pain was significant. But they're marker spots. So reviewing imaging, doing an exam, and then we come back to the consultation area and we try to put this all together. Let's discuss the reasons why I think you have this condition. I want to present you with evidence that in a sense overwhelms your fear and overwhelms your previous diagnoses, if you had some that took you in a different direction, so that I can explain to you why I think that TMS, PPD, mind-body disorder, whatever you want to call it, is the actual and accurate diagnosis for you. And right after that, we move into a detailed treatment plan discussion. I've now got it in almost the form of a menu where I say, well, I'd like you to do this from column A and this from column B and this from column C, et cetera, to give people guidance, because people like to know, what do I do next, right? What do I have to do? And it might be reading a book or two. I use journaling in almost all of my patients. We talk about that. And then, there's podcasts. Maybe I'll add this podcast to the list for anyone with
Yep.
dizziness for sure. It would be very appropriate. Here's a podcast you can listen to on this subject at no charge. Obviously, podcasts are usually available for free. And then I'd also like you to watch this movie. There've been a couple movies made about TMS. The one I like is All the Rage, and I often advise people to watch that maybe with a family member who is kind of curious about this condition but doesn't really understand it, because family members won't typically read a book for you, but they'll sit with you with popcorn and watch an hour and 10-minute movie, and can give them some perspective on the condition. It's not a perfect movie, but it's an interesting take on one person's experience with back pain, and Dr. Sarno, and he was a film director, so he created his own movie about that. And then maybe I'll also recommend an app. There's some apps that are out there we can talk about that can be helpful to patients.
Mhm.
And I may, so these are all check marks that I'm putting on a sheet so people don't have to take notes in the consultation, because I hand them the sheet at the end. And then I also may recommend different kinds of psychotherapy. So I might recommend initially to come to a Zoom group. I don't know if you're doing any Zoom groups with your clientele, but it can be very helpful. I was doing pretty much every week for 3 years. We've taken a break during the summer, but 4 to 6 patients and myself and a psychologist were a very helpful group format. I also have a great pool of TMS therapists in California, and I know a few in other states as well, including Florida.
Yeah.
And there's a TMS coach that I use as well. So the point is, individualizing a treatment plan for each of your patients or clients is very important. And I don't give the exact same recommendations to each person, because people have different needs, different awareness of the condition. Some people have, when they see me, have read nothing in this area. They just were told, see Dr. Schechter, he helped me, by a friend or a relative. Other people have read 8 books in this area, so I don't have to recommend additional books, but I might recommend an app or a movie or journaling or something else. So individualized treatment plan. So I hope that gives you a kind of a view of the initial consultation.
And what a contrast.
Yeah.
What as you were talking about this, we spent the last few minutes talking about this. I was thinking how many people are going to watch this and say, I can't believe that no one has asked me even a quarter of those questions across the 20 different doctors that I've seen to try to diagnose my condition. So thank you for sharing all of that. I have a couple points I wanted to clarify.
A lot of patients who've seen 20 or 30 doctors. And by the way,
absolutely.
These are A-list doctors in many cases.
Yeah.
And so I don't consider myself more intelligent, more educated than these doctors. However, I'm asking a different set of questions. And so by asking a different set of questions, I'm going to get a different set of answers. And that's what we can offer in this field, is not doing the same thing over and over again and expecting a different result, which, as many of you know, is the definition of insanity.
Yes.
Where if you ask different questions and you approach it from a different angle, you're more likely to get a successful result, especially in someone who has failed so many other approaches.
Right.
Many physicians want nothing to do with someone who have seen 20 other doctors and not gotten better. But I have the best results with those people, because they are, unfortunately, they are desperate. I don't like people being desperate. I like everybody to be happy and relaxed, but desperation is a great motivator for change. And this process is about learning something new and about changing. So when you have failed with many other approaches, this approach is often very effective for you.
Well, not to mention
open to it.
That if it were a biomedical problem, then another approach probably would have worked. I mean, when you've gone to see so many physicians or other practitioners. Yeah. Yeah. So to clarify something that you said, I have a couple points for clarification, but one of them, this one just popped out at me. So I know you and I have spent years honing how we talk about this with people, but you said some people I sent to psychotherapy. And I'm wondering if you can help me clear up this misconception for people. We are not saying that your pain is in your head or your symptoms, your dizziness are in your head. So can you explain just kind of the way you would explain to someone who's coming in, you were recommending this for that person?
Well, this concept of "is it in your head" is a very old concept. So here's the latest way that I discuss this with people.
Yes.
And they say to me, is this problem therefore in my head? Well, the first thing I say nowadays is I say, well, I just want to share with you that your brain is in your head and that all processing of all sensations and awareness is in the brain. And so in that sense, our problem revolves more around our brain, mind, and emotions, which, as we understand them, are mostly experienced in the head. But that doesn't mean that I'm in any way saying that your problem is fake, imaginary, illusionary, or uh, or malingering, or something that you've created yourself,
Or like a mental illness. In
or
fact,
or a mental illness, or a something that you are trying to do to yourself. Right? You're not at fault. Um, but let's start with the most powerful organ of the body. It's not our biceps or our gluteal muscle or our liver. It's our brain. Let's start working with that. So I also use the term top down instead of bottom up. So a lot of healthcare is bottom up, right? You swallow a pill, it goes into your stomach, and then it goes to the rest of the body. That's kind of bottom up. Or you're getting physical therapy to your buttocks or to your back or whatever. Again, bottom up. If we work from the top down, the brain and the nervous system, and then direct to our ears, to our vestibular, to our back, to our neck, that's kind of top down. So it's really a shift from a bottom up approach to a top down approach. And so is it in your head? Not in the way that that's often pejoratively used, but it is in all of our heads, in the sense that if we were unconscious, we wouldn't be having any pain or dizziness.
right.
If we were under anesthesia and having a procedure, surgery, or colonoscopy, we wouldn't be feeling dizzy or in pain, because we'd be out of it. And anesthesia is working on the brain. It's not working on the back. And so, unless it's a local anesthesia, we're talking about general anesthetic now. So I just think it's useful to redefine some people's concerns about that in your head thing.
Yeah. Thank you for clarifying that. I mean, I've told people, if I cut my arm's not feeling pain, my brain's feeling pain. It's still happening in my brain, whether the origin of the sense this experience was in my tissues, in my periphery, or in my brain. It's still my brain that's perceiving pain. The
Right.
same with dizziness.
Processing all the signals from all over the body and deciding what to focus on and what to ignore. And that's a key element to the healing process, and a key element to a number of conditions, including, I use that a lot with tinnitus. But the brain is doing that sensing and that perceiving and that distinguishing what's important and what's not.
So another thing that you actually mentioned that I wanted to pick up the thread on. So you mentioned these musculoskeletal conditions, and I know neck and back are your area of expertise, but we have on my channel a subset of people who have associated tension with or pain with their dizziness that's sometimes being blamed as the cause of the dizziness, or the dizziness is being blamed as the cause of the tension, and specifically neck issues. So we have this whole category of cervicogenic dizziness, aka dizziness associated with the neck. And then we have TMJ. Some people are also being told their symptoms are the result of TMJ issues. So I'm wondering if you have a take on that to start us off.
Well, the neck is often tight and the TMJ is often tight, but the cause of chronic neck pain, the cause of chronic TMJ pain, the cause of chronic dizziness is usually TMS, psychophysiologic disorder. And so they're saying something that's true, that you have both neck tightness and dizziness, but they're not really looking at the true root cause of it. They're just describing what's happening at the present moment.
Mm-hmm.
I mean, if you absolutely couldn't figure out the stress of the day and you got a neck massage, you might feel better in the neck and you might feel better with your dizziness somewhat, but it would be temporary. And so you're really looking to go beyond having to spend $50 or $100 or $150 for massage in order to get temporary relief. You're looking to do things that are going to give you long-term relief from your issue.
Right, right. So what are some of the indications then when people have these kind of linked symptoms? Again, in particular neck pain, that's the big one, but sometimes this TMJ discomfort as well. What are some of the indications that what we're dealing with here is truly a psychophysiologic disorder, aka mind-body disorder, TMS? So I know we've used all those terms today. What's the indication that that's actually the root cause, and it's not that 20-year-old whiplash injury or chronic neck tightness, or impingement or stenosis, these are things that I see blamed a lot,
Yeah.
are actually the cause? Like what's the indication for you that that's actually what's
Okay,
happening?
so there's two types of ways to looking at. One is, so what have you done physically to relieve that? Because most of these people will have tried chiropractic, acupuncture, massage, physical therapy, and if they haven't gotten better from those things, or they've only had brief temporary relief, I would say, well, let's try something completely different, because obviously those things haven't fixed the problem.
Mhm.
So if the problem was a tight neck, those things should have helped in most of the conditions that are fixable by external treatment. I didn't address maybe stenosis per se, but certainly the other ones. And then the other thing that we're again looking for is the personality type. We're looking for someone who is a worrier, someone who's hard on themselves, someone who's puts a lot of pressure on themselves. And this is the type T personality constellation that Sarno first described, and that I brought together with this terminology type T so many years ago to give it a specific codification, like type A personality, type B personality. Some of you have heard of that in relation to personality, heart disease, intensity, etc. But anyway, getting back to you've failed other treatments, and you have this TMS prone personality. Beyond that, as a physician, I can look very closely at their imaging and kind of give them a sense of whether I think their imaging is anything more than gray hair of the spine or normal aging.
Which I'm going to come back to in a moment. I'd like to hear more about that.
Is it specific enough to cause neck pain, much less cause dizziness or other symptoms? As an audiologist, you have a little bit harder time with that, because you're reading reports, of course, of things, but some of the terminology can be frightening. One of the worst words that medicine ever invented, I mentioned in some of my writing, is degenerative. It's a horrible term.
Yes.
It means wear and tear, but people think they're a degenerate or they're degenerating. It's a terrible word, and it's used in radiology reports. So many radiologists are, unfortunately, I could use the term lazy. I think I will. And they say, instead of saying there's wear and tear of the spine commensurate with a person's age of 53, they instead say there's mild degeneration noted in the C3, C4, this type of thing, right? Talking about the cervical spine. And some very good radiologists, including the Stanford Department of Radiology, which I occasionally get a report from, that's in Northern California. I'm in Southern California, but I occasionally get a report from them. It'll say at the bottom of the report, it has a little paragraph they use, which is great. So it'll say, 40% of people age 35% or over have at least one bulging disc. So they give some of the data that Sarno looked at years ago and included in his writings, that I've included in my writings, which really point out that imaging of the neck and back, and other parts of the body for that matter, is often too sensitive, meaning it finds too many little things that don't mean anything. And, we give the analogy of gray hair of the spine, because you can have gray hair on your head and it doesn't hurt your head. It doesn't hurt your head. So you could also have aging changes in other parts of the body that don't hurt. And again, I'm not denying the existence of severe arthritic hips that occasionally need to be replaced, et cetera. There are conditions that do lead to changes in the body that might merit surgery, but they're very limited compared to the number of reports that have findings that really aren't very relevant. I mean, if you've hit 40 and you don't have at least one bulging disc, maybe you should rethink your life. You haven't done enough things. Right?
Yeah. Only the good die young, right? Yeah.
Out there, play volleyball, do something else. But in any event, there are a variety of changes, and the problem is it's like a pin the tail on the donkey thing. So I remember that kids game where you're trying to pin the tail on the donkey. So the physicians are looking to always pin the diagnosis on something. And if they don't have a clear explanation, and if they don't understand psychophysiologic disorders, then they say, oh, look, your x-ray has this, that's the cause. And I've even seen doctors, supposedly well-trained, blame a right-sided disc for someone who has pain on the left side, which makes no sense whatsoever. And, I go to them, wait a second, your disc is on the wrong side. Did he even ask you where you're hurt? No, he just kind of looked at my imaging. I could tell you stories like this all day. I'll give you one very brief one because it's just so powerful. So this woman was having back pain, and she had MRIs, and she went to see a specialist who was a physical medicine rehabilitation doctor, not even a surgeon. And she actually felt pretty good that day. So she walked into his office somewhat briskly, sat down in her chair, and he's didn't even like look at her, didn't talk to her, didn't ask her questions. His assistant had gotten some preliminary information. He throws up the MRI on his computer or his screen. Nowadays we look at them on discs and things, and he goes, "I'm shocked you can even walk." Now, this is a woman that had actually walked into the office and was feeling pretty good today, although she did have chronic back pain. And he hasn't even examined her. He hasn't even taken a history. He's looking at pictures. The key thing in medicine is you don't treat the images, you treat the patient. Yeah. But this is an extreme example of that. So that woman was traumatized. And, I do a lot of deprogramming. Yonit, I'm kind of a deprogrammer of people because they've been programmed sometimes to believe that something's wrong with them. You do this too, I'm sure. That is not relevant. And I have to explain to them why. And I have to kind of deprogram them from that false belief that's hindering their healing.
Yeah. Yep. I do this a lot. I do this with people. I mean, in many cases, there's no finding at all, but they've still been told you have this is the diagnosis. This means you're never going to get better. Maybe we don't know what's going to happen to you. Good luck. Here's an SSRI. And then some of them have, I wouldn't call them maybe normal abnormalities, but abnormalities that don't lead to symptoms in many people. And for those people, I think sometimes the deprogramming is more difficult because they can point and they say, but they found this weakness on this side, and then this must mean, right, this explains the dizziness. Well, no, not if you're dizzy 3 years later and you got better, and then suddenly the dizziness came back, and your physical therapist is saying, oh, you decompensated. What is that? I'm going to go off on a tangent.
Yeah, and also you might find that they're better on vacation, or they're better on the weekends, or they're worse on the weekends, depending on obviously their lifestyle circumstances. So there's a lot of patterns if you dig into it that make no sense from the standpoint of, oh, it's purely a structural thing. And then, there's a lot of studies that have shown that MRIs of different parts of the body do not correlate well with symptoms, that people can have the same MRI during periods where they have no symptoms, and then, they get symptoms, they get another MRI, and it hasn't changed. So it's not really as sensitive a test as we sometimes think it is for many conditions. It's good if you tear a knee ligament. It's good to tell you that.
Yeah. So with these normal abnormalities, then I'm curious, what's the latest? I remember reading a study on necks specifically that was just some incredibly high percentage of people. So what percentage of people approximately have normal abnormalities or just kind of normal gray hairs of the spine and neck that don't have symptoms?
Yeah, well, bulging discs in the neck are even more common than in the lower back, and that was just discovered in the last 10 years, I think. These studies are done by finding 50 people with neck pain and 50 people with no neck pain at all in a particular city, and offering the 50 people with no neck pain $50 if they'll lie in an MRI scanner for half an hour. A lot of people take them up on that. And then comparing them to people, let's say, with a neck condition or neck problems or whatever, putting them in an MRI scanner. They're happy to get the MRI because they have neck pain. The other group didn't really want to get the MRI, but for $50, they'll lie in an MRI scanner for half an hour and get it. And so something like 70% of people over the age of 30 or 35 have changes on a cervical MRI. It's really remarkable. It's like, well, so you've really got to be careful about diagnosing anything off of that, right? So just to give people, it's not that I ignore every imaging finding. So if somebody had neck pain shooting down the right arm, and they had numbness in their thumb and index finger, and they had a specific herniated disc at a specific level, well, that could be significant. That's structural. That all fits together. So there are cases where a herniated disc pushing on a nerve to one side with classic symptoms down the arm is significant. Doesn't mean that person necessarily needs surgery, but it likely means that there's a structural cause for that symptom. But that's very different than these 2 and 3 millimeter bulges and 1 millimeter bulges and multiple bulges and mild stenosis here and mild this and mild foraminal narrowing. These are very common changes that just occur in our neck as we live on the planet with gravity and physical activities. There often may be a genetic component too. There've been some studies that looked at identical twins, one of whom was into football in high school, and the other one was on the chess team. You want to play football. And they looked at their MRIs 20 years later, and this is amazing, but both of their neck MRIs look very similar, despite the fact one played football, one played chess. And we know chess is not that hard on the neck. So it seems like there's a genetic element to the changes that occur over the decades as we get older, not just wear and tear from physical activities. And so even less reason to worry about it, just like there's genetic reasons why some people lose their hair, some people get gray earlier. There's people gray at 35, people gray at 70. So there's different patterns that don't mean a pathology per se.
Okay. So in your opinion then, and this may be really more of an opinion than settled science, I recognize that. When people have dizziness that does seem to be related to their necks, so it's either accompanied by neck pain or specific movements of the neck really seem to make their symptoms worse. But again, they have these chronic problems and nothing really seems to explain why they have the symptoms. There's no real structural explanation. In your opinion, does that still fall into the category in many cases of a psychophysiologic disorder?
Yes, I would say, well, there's a couple thoughts on that. First of all, the treatment that you offer and the treatment that I offer for patients with psychophysiologic disorders is non-invasive and not dangerous. And so that's something to take into account, which is if there is this sort of, well, there's a little bit of this, a little bit of that. I talk a little bit about this concept of mixed picture in my book. I don't know that we want to get into that today, but it sometimes confuses patients, but it's often helpful to people or realistic. But the treatments that we offer are very non-dangerous. They're because they're non-pharmacologic, they're non-invasive. And so if you have that you're on the fence a little bit about this. Well, they get a little worse with certain movements. The neck, it seems like when the neck loosens up, the dizziness improves, etc. It's still worth approaching this if you have the other checks on the box that we talked about in terms of personality type, past history, functional disorders,
adverse childhood experiences,
that type of thing. It's worth exploring this area if they're open to it. And it's really a benign approach to their problem. We have found that the stronger the patient believes in the approach, seems like often the faster they get better.
I was just going to ask.
Yeah. And so when you start getting into these sort of more hazy cases or potentially mixed picture cases, it's kind of like asking the person to believe most of the time, but it's okay to not believe some of the time. It gets a little bit more challenging, but I find that I can still get very good results because maybe it gets back to that virtuous cycle again, which is that success builds on success. So if a person journals or a person reads a book or a person introspects about their emotional life and then finds, boy, I had a really good week after I wrote about these feelings, and I had a really good week after I talked to my spouse about these concerns in my life. Well, that makes them think, well, maybe there is a psychological element here, so that can kind of build on itself. So you're offering another way of looking at a problem. You're offering another perspective that some people will reject immediately, although the ones I think seeking you out are very often seeking me out, obviously, or at least somewhat open to this. Mm-hmm. But you're also offering a chance to try something that there's personal growth involved. I mean, getting a shot into your ear or your neck doesn't provide you any personal growth, whereas doing this work, you get an added benefit of hopefully symptom relief plus potential for a little bit of personal growth, more awareness psychologically. Those are good things. And so when in doubt, you can always say to somebody, look, I think that this is the right approach. I can understand why you're having these doubts. Why don't you give it a month or 2 months before you before you give up on this approach? Try to really throw yourself into this for a month or two. And that often makes a difference with people.
Mm-hmm. Yeah.
Sometimes, I don't know if you work with psychotherapists in your community or your work much, but sometimes,
I refer a lot.
Okay.
Yeah, I do.
Sometimes adding in the psychotherapy piece, and maybe offline later we'll talk about who you refer to, just for curiosity.
Yeah, we should talk about it. Yeah.
But sometimes adding the psychotherapy piece, and people find a listener who's trained and to be empathetic and trained to understand their emotional life, that also takes them forward in understanding this, especially if it's the right person. So we don't just refer to general therapists. We refer to people who are aware of the TMS mind body approach to pain and other symptoms.
Yeah, I mean, and really, it's almost like when you're describing this, I'm thinking, okay, so let's just say there is some kind of biomedical or biological component here. I mean, the biopsychosocial term is already problematic because there's really no distinction between those three things. They all affect each other. But for the sake of this discussion, all experiences are biopsychosocial. They're being influenced by all three of those things. And some things maybe on that spectrum have a little bit more of a biological contribution.
Yeah.
And some things are completely psychosocial, and like the biology is kind of a side effect of the psychosocial components.
Yeah.
So I think anyone can benefit from the approach. And so what I encouraged to hear was that you're not dogmatic about saying someone has to believe fully with all their hearts or there's no benefit to it, because ultimately, again, there may be some kind of biological component for some people that maybe isn't going to respond as well to the techniques that we talk about, but that biology is influenced by the psychosocial components we work on.
Yeah, no, absolutely. I think what you're saying is absolutely true. I mean, let's think about a biological event. You rupture a ligament in your knee. But after the operation is done to repair the ligament, there's a lot of psychosocial involved in who gets back to sports, who has a lot of fear, who takes 2 years to get back to sports, who takes 6 months to get back. There's a lot of psychosocial elements even in the recovery from a biological injury. So that's one example where, as you said, biopsychosocial all figures in, sometimes at different points in the thing. The other thing is that I'm willing to take on, as you said, I'm willing to take on the skeptic, but not the 100% cynic. If you're not open to this at all, it's really not the right approach for you right now. Doesn't mean it couldn't be in 3 months or a year. There's a lot of patients who are gifted a book, my book or Sarno's book or something. They initially find it off-putting or ignore it, put it on their shelf. But it's amazing how many of them have picked it up 6 months or a year later. And then they read the book in one stretch. They read it over a weekend. And they're calling my office at 9 a.m. on Monday saying, how soon can I get in to see Dr. Schechter? So they had the book for 12 months. They could have made an appointment, obviously, at any point. But suddenly that weekend, it made sense to them. So that's called readiness for change. There's a lot of psychological literature on that. Some people are not ready. So I'm willing to take somebody who's a little bit skeptical as long as they're open. I'm certainly willing to take people who are more enthusiastic to the approach. Mm-hmm. I've had people who've come in to see me for thinking they had TMS, and I had to say to them, no, I think in your case, it is a structural problem. And so if I didn't ever say that, I think I wouldn't be considered really an objective observer or an objective physician / scientist, whatever you want to say. But in the vast majority of people, they are able to correctly self-categorize themselves in this. But every so often, people are wrong, and that's okay. They appreciate my honesty. I have no skin in the game. I don't do surgery myself, and so it's not that I'm doing surgery on them for some type of gain or whatever. But somebody who's somewhat skeptical, you try to explain, and then you give them a little bit of time. You give them some reading assignments. You give them some other things to do, and you ask them to observe whether there's an impact about how they think and how they feel and how their symptoms are. So again, we don't do pain diaries, right? Pain diaries was a mistake. That was something created decades ago in the pain medicine field. The doctors would say, write down how much pain you're in every day. If you write about pain, you get more pain. If you write about dizziness, you get more dizziness.
Yes.
If you write about your feelings, you might get less of both of them. And so that was the mistake in the pain diary thing. So that's why the journaling we do is about emotions and feelings and experiences. It's not about your symptoms per se. At least that's the way I do it.
Absolutely. Absolutely. I've had to give some people some long lectures about why I don't want them journaling about their symptoms.
The more you about your pain, the more pain you get. So
airtime. You're giving it more airtime. Your brain gets the message. It's important.
Yeah. So we're on the same page with all this stuff, which is great. because you move away from paying attention to it, you give it less credibility, and it fades. And that's true of dizziness, tinnitus, back pain, lots of stuff.
Yeah. Yeah. Well, that actually raises another question for me then, because I know, so Dr. Sarno was very dogmatic about other types of symptom relief. So chiropractic, acupuncture, massage. So where do those fit into this, do you think? So if someone's having neck, for example, neck pain, right, associated with dizziness, can they do those things, or are they sending their
Well,
brains a message of danger?
okay, so if they've been doing physical therapy when they come in to see me and they haven't gotten better, I usually say to them, "Look, you've tried that already. Why don't we move on to something else?" The physical
But what if
therapist.
it's the one exercise that they just haven't done yet?
Oh, it's the
I'm
one
kidding.
exercise they
Yeah,
haven't done yet.
yeah, I'm kidding. Like, there's always one other well, we haven't tried this exercise yet, so
Well,
obviously that's the
I
issue.
sometimes said to people, why don't you take a couple weeks and do that and come back and see me when you're ready to kind of delve into this a little bit
Yeah,
further. If
yeah.
that works, then just send me an email telling me it succeeded. So that would be one approach to it. The other thing I use is something called the hierarchy of treatments. This is self-treatment usually. So somebody will say to me, what do I do if I'm having a bad, weekend? And X can help me temporarily. So I'll say to them, let's try the hierarchy of treatment. So the first step in the hierarchy is talk to yourself. Think about it, right? Think about your pain. It's what's stressing me, what's bothering me. Am I upset about things? Am I angry about something? So it's the emotional, and sometimes that gets rid of it. The second step might be something like distraction, which is okay. It's benign. I'm not going to worry about it. I'm going to go chip some golf balls in the backyard or something like that, right? So that could be the next thing, distraction. Okay, that didn't work. So what do you do next? Okay, now it's okay. And I'm not as dogmatic as Dr. Sarno on this. So now it's okay. You could use heat, or you could use ice, or you could put heat on your neck, or you could get in a jacuzzi, or you can get in an ice bath in Florida in the summer or something like that.
Sounds good right now.
And try that. And, what if that doesn't work? It's Saturday night and I'm really in a lot of discomfort. All right, so take some Advil or relief. Sometimes that gives you some relief, or Tylenol or something like that. So I call that the hierarchy, right? We would love the first thing to work. If that doesn't work, hope the second thing works. But sometimes you're a human being. Sometimes you're going to need to use, especially early on in the recovery process, you might need to use one of these things. So I give them permission to do that. However, to do physical therapy or acupuncture or that kind of thing over and over again at the point at which you're in TMS program mode, I think that's counterproductive in general. So I do come to the same conclusions as Dr. Sarno on that. Find that to be counterproductive because it could be what the physical therapist says. It could be what they're between the lines, what they're saying, or it could just be signing in as a patient. I'm trying to demedicalize your problem. I'm trying to take you away from the healthcare system that has not served you well and has probably cost you a lot of money. And so to do that, it doesn't make sense to sign in at a physical therapy clinic. Oh, I'm here as a patient, Tuesdays and Thursdays.
Right, as a neck patient
If,
or
on
as
the
a
other hand, you
yeah.
go to the gym and work out, and one of those exercises you do is neck rolls, fine, do it for flexibility. People say to me, is it okay to stretch? And I'll say, try not to stretch for the purpose of curing your problem. Try to stretch for flexibility. Try to stretch for youthfulness. Try to stretch for pliability. There's a lot of reasons to do stretching that's fun, that there's no reason not to do it. You just can't get absorbed with, oh my God, I missed a day of stretching. Now I'm going to be in agonizing pain tomorrow. Try to get out of that mindset. As you see that type of thing. So, it's somewhat is like the belief and then the context in which you do things.
Yeah, yeah, I completely agree. So it's okay to think of it as symptom relief, but it's good to make sure you're framing it that way. I often tell people, if you're going to do it, say to yourself, "I'm doing this as an act of self-compassion. I am choosing to do this as an act of
Yeah.
self-compassion." If for people with dizziness, sometimes it may be taking a dose of meclizine or even a dose of Xanax for some people. I mean, it may be that they have to. It's at the top of the hierarchy, but they're in distress. But
Or
it's
lying down in a quiet room,
right.
etc. By the way, if Xanax helps you, Xanax being alprazolam, it's a psychoactive benzodiazepine related medication. If that helps you, to me, it speaks more to anxiety being a factor in your
And the
dizziness
symptoms.
than anything
Yeah.
else.
Yeah.
I know it has other calming effects on the central nervous system, vestibular system, etc. But
Yes.
it's not primarily, that's not its primary physiological effect. So, it does speak to, I mean, I have another patient who he said to me, the only thing that ever relieves me is Xanax. He says, Advil doesn't help. Tylenol doesn't help. This is for pain. I said, well, that tells you something, because
Yeah.
those other things actually are painkillers.
Yeah.
If it's not a painkiller, this is an anxiety crusher.
Right.
And so if your anxiety is really high, that would explain why this is helping you with your physical symptoms. That speaks to the mind-body
Yeah.
condition more than anything else. So that's
Yeah.
kind of interesting what helps people. But yes, self-care, self-compassion, that's a good reason to use those things rarely if you can't get relief with the program that we teach, the
Right.
journal,
Agreed.
self-talk, etc.
Yeah. Could we spend a few minutes on that? I know our time is short, but I'd love to hear just a little bit about your workbook and kind of just maybe a summary. Like what are we trying to do? So besides reframing the symptoms themselves, because we talked a lot about that and how that initial thorough examination matters, the way we talk to people matters, taking them out of being a patient matters. But a lot of people need to go deeper than that.
Yeah.
Especially people who've had adverse childhood experiences, but often not. So what's kind of the main objective behind the journaling and the emotional work?
Well, expressive writing or journaling has actually been around for a long time, and there's a tremendous number of research studies showing its beneficial effect for a variety of physical and psychological conditions. And they're not well known because in the medical field, we don't have, we have pharmaceutical representatives pushing medications. We don't have Staples representatives coming over with $2 notebooks saying, "Hey, you get people a notebook and tell them to write in it." You know, there's no money by any. You know,
There's
Eli
no notebook lobby. Yeah.
out with a new brand of notebooks for $1. You can get them at your 99-cent store. That's
Right.
not that the pharma industry is really particularly interested in. So
You joke, but I do think that that's a contributor to why sometimes these methods are not advocated. Yes.
yeah, I mean, I think if Nike spent more time in doctors' offices, maybe people would talk about exercise more with their patients. But in any event, not everything is driven by money, but a lot of things, unfortunately, are. Yeah. With regard to what we're trying to accomplish, expressive writing, it could simply be sitting down with a blank notebook and writing about the things that upset you that day, the things that made you angry that day, the things that made you happy that day. So you're writing about your feelings. And at a level beyond just describing your feelings would be trying to understand your feelings. So it would be trying to connect it to things from the past, what life was like in your teenage years or your childhood years that made you feel similar to the experiences you had that particular day. That may not come out in the first day or the first week. What I found in using, Sarno had mentioned journaling in some of his early books, but never really elaborated on it a tremendous amount. What I found using it in the mid-90s, this is now quite a while ago, was that patients often burned out on writing after a few days because they couldn't think of what to write about. So 23, 24 years ago, I wrote the Mindbody Workbook. It's been out for quite a while to give people a guided journal. So the idea of a guided journal is you get questions from the author that prompt you to think about different areas of your life. And those areas of your life might be your work, your relationship with your family, friends, childhood stuff, etc. So that, there's different questions every day, and it gives you a chance to not have to think about what to write, but to be prompted. Some questions will be highly relevant, and you may want to write a page on those, and other questions will be a little less relevant. You may either want to skip them or use them as a springboard to doing some more writing on something related to that. So that's the idea of guided journaling. And as I mentioned earlier, I wrote a new Mindbody Workbook Volume 2 with a psychologist with a whole new set of questions. And we actually have affirmations every day as well, because that's a technique that I've been using as well. So the idea, as you mentioned, is get the feelings out, and understand the feelings. Understand what drives the feelings. And it's the cheapest form of psychotherapy imaginable, because as we know, psychotherapy can be 125, 150, 200 an hour or more. And it's very valuable. And these therapists are definitely worth the money that they charge. But a blank notebook is $2 or $1. And the Mindbody Workbooks are $15 or $20, and you've got them for 30 days worth of prompts. So they're very cost effective compared to therapy. And if you're doing therapy, they can also add to your benefit, because your therapy is 50 minutes one time a week for most people. What do you do the other hours of the week? So by doing 15 or 20 minutes of journaling 3, 4, 5, even 6 days a week, you've got something great to talk to your therapist about when you show up or when you get on the video that 7th day to talk to the therapist. You've got a lot of stuff that you've kind of written about.
Mm-hmm.
And so I think it can help make therapy work more effectively and more quickly, and identify some of the key issues, because you'll see what keeps coming up. And then if you're working with a therapist, they can help you go deeper. And if you're not working with a therapist, as you go week after week in your journaling, you try to peel back layers of the onion and look a little deeper at yourself and try to understand yourself as best as you can. So that's the basic concept. It's a very useful tool. It's very portable. It's inexpensive. And everyone can do it, although it's not easy for everyone to sit down and do it. The ideal thing is to do it in long form handwriting, just to write it out. If you really detest writing, or you don't have access to a pen and a paper where you are, you can do it in your computer with typing.
Or voice memos if necessary. Yeah.
I'm sorry?
Or voice memos if people are dizzy and can't look at a screen or a piece of
Voice memo
paper.
is the third option. And there's research that kind of suggests it's in that order in terms of effectiveness: writing, typing, and voice memos. And again, for some patients who are very, very busy, I say to them, put an index card in your pocket or your wallet or your purse, and just literally fill up the index card at work once a day. It could literally 5 minutes. It could take 3 minutes, 5 minutes to fill up the index card with emotional stuff. And if you want to put it in the shredder, then fine. If you want to put it back in your purse or pocket and bring it home, that's fine. But at least it gives you a chance to have a little bit of a stress break and a stress release, especially if something makes you upset or angry at work, and you would tend to internalize it, stuff it inside, and it maybe comes out as physical symptoms.
So is that the main objective then, working through these things? The emotional expression itself has its own value then for reducing stress. And then is that kind of the main objective, or is there something more processing this?
That is one of the main objectives, is the simple release of stress and tension and pressure. The second objective is understanding yourself so as to prevent so much stress and tension and pressure.
Yes.
And the third effect is just to have an overall kind of calming on the nervous system. We talk a lot about hyperexcitable nervous systems and how it contributes to dizziness, pain, nausea, other symptoms that patients have with the mind-body conditions. And it just like meditation can be calming, journaling can be calming, although it can sometimes be a little tension-provoking during the experience. It's very calming after you've done it, after you've had that release. Some people will have an emotional experience when they journal. They may cry. I've had some patients say that they try to hold the pen tighter when they're angry, and they kind of write differently when they're happy, or so they sometimes can do it that way. If you're an artist, you might want to intersperse writing paragraphs with drawing something. I don't have those artistic skills, but if you do have that, you can draw things that are meaningful to you emotionally as well. So there's lots of things you can do with that journaling time. And it doesn't take a lot of time. Many people will do it at the end of the day. If they have young children, they do it after the kids go to sleep. Other people prefer to get up very early and do it. It's whatever works for you. But I would say the majority of people do it later in the day, because then you have kind of the whole day simmering in your conscious and unconscious mind to write about. But whenever you do it is good. And you don't have to be a perfectionist about it. You don't have to do it 7 days a week. I have it's a 30-day Mindbody Workbook, but I know that many people take 35 or 40 days to get through it. That's totally fine. It's got 30 days of content, actually a few more days than that, 31, 32. But, it's just something to do. And then when you finish the workbook, you have now volume 2, or vice versa, or you use a blank notebook. I tell people, if you've journaled for 30 days in a workbook, you've probably got like a bachelor's degree in journaling. Now you can go on and do your own journaling in a blank notebook or voice memo, or however you choose to do it, because you now have the awareness of what it's good to write about, what is good to.
Exactly. Gives you some insight about what the core issues really are when you've done it. Yeah. Thank you. That makes a lot of sense. And I have found this conversation so delightful and so enjoyable. Again, it's so neat to have you here on my channel. And I know that everyone watching this is going to get a lot out of our conversation as well. Just wondering if you had anything else you wanted to share, any words of wisdom you wanted to share with someone who's going through chronic dizziness.
Well, I was just thinking about, you and I have never met, we've never spoken on the phone till just before the recording.
Yeah.
We emailed once or twice, and it's amazing how much we have. I mean, how much we see in common, how much we see these conditions in a similar way and approach it in a similar way. So I think that speaks to the commonality of mind-body practitioners who've been influenced by Dr. Sarno's work and other work in this field. So I think that's kind of interesting and exciting for people out there listening, that there's a small number, but there's more and more people doing this work, also internationally. I was traveling in Israel this May, and I spoke to a group of doctors and psychologists there who were interested in this work. So
yeah,
kind of planting a little seed. Now they have their own organization. They're meeting regularly. I'm thinking maybe I'll go to pick another small country. I'll go to
I know.
try to get some people interested there. But
I just spoke to Serpa.
Serpa
Last month, I gave a presentation to Serpa.
Oh, that's great.
Yeah.
So there's a lot of great work being done, not only in the U.S. But also in other countries and continents. And just if you're listening to this, be open, explore the work honestly and openly. And in my experience, you can get great results with dizziness and other symptoms that you're struggling with if you stick with it, work with Yonit. And there's
watch all the videos. Watch all the videos.
Lots of good resources out there.
Yeah. Thank you. Thank you, Dr. Schechter. And again, thank you so much for your time today and for your patience with the various internet problems I've had. I'll be editing some of that out, but if any of you saw the freezing, we're in a heat wave here, even for Florida. So my internet keeps going out. So thank you again, Dr. Schechter. I really appreciate it. Thank you. All right. And folks, if you enjoyed this interview, please like, share, subscribe to my channel. And of course, if you have questions or comments, drop them below. And I look forward to hearing from all of you. Thank you and take care.